Hello, and welcome to Ask Dr. Mingle, a Q&A series from Mingle Health where we take your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and executive chairman of Mingle Health. Good morning, Dr. Mingle.
Good morning, Kyle, and a good day to all of you tuning in. It's great to see you again. I'm Dr. Mingle. I'm Dr. Dan Mingle, and I'm here to answer your questions to the best of my ability.
Before we get started, I want to invite our listeners to send us their questions for Dr. Mingle. You can leave your questions in a comment on LinkedIn or YouTube, or you can email them directly to us at hello@minglehealth.com. And we have two great questions today. Are you ready, Dr. Mingle?
I'm ready, Kyle. Bring them on.
Our first question today comes from Maria, and Maria asks, how will MIPS Value Pathways work for small practices who are automatically reweighted for promoting interoperability? Will CMS still reweight the PI portion of an MVP for small practices, since it's the basis of the whole MIPS program?
Well, thanks, Maria, for the great question. Medicare does not explicitly say that small practices will continue indefinitely to get the promoting interoperability, that is PI, reweighted in MVPs. But I don't think that Medicare intends to end reweighting for PI for small practices anytime in the near future. In fact, they doubled down in last year's final rule regarding their ongoing concerns and commitment to small practices, and specifically citing the intent to continue automatic reweighting of PI. Now, of course, you know Medicare, their plans can change on a dime. This isn't the kind of thing that would change outside of the rulemaking cycle. So whatever they say whatever they said last year in the rules can disappear in any final rule coming up. Now, again, I don't expect it to, and even if it doesn't, this is the type of thing that could get royally screwed up if it's not set in concrete. So the proposed rule for 2023 is out. It's the due date for comments is coming up. It'll be early September. I don't know exactly what the date is yet. Formal publication in the Federal Register won't be until the 29th of this month. But it's a great opportunity to comment on your needs and wants in the rules. So it wouldn't hurt to keep in mind every time a proposed rule season and the comment period comes around, you may want to comment about your concerns about automatic reweighting of PI for small practices. Thanks again, Maria, for the great question.
Yeah, thank you, Maria. Our second question today is from Jim, and Jim asks, we're transitioning out of the Oncology Care Model and into MIPS. Are there similar measures to what we've done in OCM that we can also use in MIPS?
Thanks, Jim. Great question. So, of course, the Oncology Care Model is ending this year. There are 6 measures in the OCM measure set. One of them is a survey measure. You need a survey vendor for that. And the specific survey that you're using is not available in MIPS. The CAPS for MIPS survey is available, but again, only to practices of 25 providers or more. So you can choose to use that, and you're not required to if you're a practice of 25 or more. There's 2 administrative claims measures. One, emergency department or observation stays that did not result in hospitalization. And the proportion of patients who died in oncology care who were admitted to hospice prior to death. And neither of those measures is offered at this point in the MIPS data set. Something you could see in an oncology MVP coming up. But the 3 submittable measures in the oncology care model. One, pain intensity quantified is a MIPS measure. I think nearly precisely the same specifications. It's called MIPS number 143. Plan of care for pain is there. That's MIPS number 144. And screening for depression and follow-up plan, that's MIPS number 134. Now, remember, as you make that change from the oncology care model to MIPS, the submission expectations and methodology changes. It's predominantly it's designed to be a manual abstraction of charts for the oncology care model, submitted manually through or by exchange of an Excel type spreadsheet or something equivalent through a couple of specially contracted vendors for Medicare. In MIPS, your options are a little different, and the requirements are different. We're now at a point where Medicare expects all patients and all insurers to be included in the measurement, and you get your choice of vendors, and these are all measures that we, as a qualified registry, submit. There is an oncology hematology measure set in the set of specialty measure sets that Medicare publishes. There are 20 measures in that set, which brings me to the point, though the 3 measures of the oncology care model are available in MIPS, you need 6 measures for a full measure set in MIPS. So you'll need to choose 3 more. They don't have to be from that oncology hematology measure set. They can be any measure in the MIPS measure set, but you'll need 6 or a good reason not to submit 6 to get full credit for MIPS quality. Oh, and one more warning: as you make the transition, you'll have part of this year that you're in the oncology care model and another that you're in MIPS. When you submit for MIPS, you submit an entire year of data, even if part of the year is in the oncology care model. So that registry submission not only is all patients of all insurers that are qualified by the measure specs, it's also the whole year.
Yeah, great question, Jim. And we know that transferring out of one program and into MIPS can be tough. So if we can help, let us know.
Well, thanks, Jim. Thanks, Maria, for the great questions. I want to be helpful, and I want this to be useful to you. Don't hesitate to correct or supplement my answers. Share your experience, ask your questions. We can be smarter together.